I'd like to welcome everybody and warm welcome to Dr. Price for agreeing to share his very busy time with us. As many of you know, Dr. Price is in Indianapolis, United States, where he has a very busy surgical practice, refractive practice, as well as research practice going on. I'm very indebted to Dr. Price because this is where I did my fellowship. So what I know from cornea, I came into the program not ever having put in a single corneal suture. And so whatever I learned in that year was very valuable, and I'm very grateful for the teaching I got. And so Dr. Price is really a world leader when it comes to corneal transplants, really pushed the envelope when it came to endothelial keratoplasty, and has lots of papers, videos, courses, email listservs, communication with people around the world, and even an instructional course that he offers for endothelial keratoplasty and other kinds of transplants. He's based in Indianapolis and is, I think, very lucky to have also Marianne, who Marianne is his wife, who does a lot of the research component of the cornea research that's being taken place there. And I thought it would be great to have Dr. Price speak to us for as part of our Precision Cornea Center rounds on the advances in DMEK and DSO, DWEK. Where does the future lead? I think really Dr. Price has kind of his finger on the pulse of what's happening. And as usual, we're going to be looking forward to your talk and learning lots. And this will help with what we do in our practices. So thank you so much, Dr. Price, for again agreeing to talk to us. And I'll hand it over to you.
Well, Kashif, thanks for the kind invitation to talk and the introduction. And as Kashif knows, I love cornea, so this is going to be a fun talk. Let's see here. I got to get, there we go. So these are my financial disclosures. Only relevant ones are Aerie Pharmaceutical and Hog Stripe. Now, the learning objectives are to understand the latest management options for Fuchs endothelial dystrophy and to describe the surgical techniques to optimize our outcomes when we treat these patients. So, to do our learning objectives, we're going to start out with some questions here. And the first question is, what would you recommend for treatment for a patient with decreased vision for Fuchs dystrophy? And we have some choices here: penetrating keratoplasty, DSEK, DMEK, DSO, or something else. And just let me know when I should move on. Are we going to show? Okay, here's what we're going to see. Wow, 75% recommended DMEK. That's great. Okay, well, let's go on to the next question. Just to keep everybody honest, if you needed visual correction for Fuchs, what would you want? Oh, it changed here. 60% DMEK, 20% DSO. Interesting. And then here's the last question. In 10 years, do you think we'll be doing more corneal transplants than we did in 2019? I didn't say 2020 because I think a lot of us have been out of business for a few months. So in what we did in 2019, simple yes or no. And why don't we just check the answers on this? Interesting. Well, we'll compare and see what everybody says at the end. So we'll get going here. So when we're trying to decide what to do with our Fuchs patients, we need to consider when to do a graft, which type of graft, and then if we're going to do surgery, you know, how are we going to do it for orientation marks, insertion, unfolding, PIs, and such. Now, as Kashif knows, when we go to decide when to operate on somebody, we don't really use some of the old things like pachymetry. We go purely on patient symptoms. Are they having difficulties, like with glare, seeing detail? And then when you're going to decide when to operate, it's also going to be influenced by which technique you're going to use. How reliable is the visual recovery with the type of surgery you're going to do? And I think if you use DMEK, you're going to intervene sooner than if you use DSEK. Also, we need to think of the risk and complications. So the experience of the surgeon is going to make a difference as to how soon you intervene. The situation of each patient is going to make a big difference. You're going to treat somebody from a nursing home different than somebody that has to drive at night for their living. And for each option, you have to think about when you do this surgery, how is that going to affect the eye if you have to do a graft in the future? And for instance, the biggest consideration there is if you're going to do a penetrating keratoplasty, that always makes it really difficult in the future. So I essentially do DMEK for all of my Fuchs patients as compared to DSEK. DMEK has a better profile, fewer rejections with the same steroid dosing. Less steroids are needed, so you have lower IOPs, better visual acuity. And something that's not always discussed, the donor prep is much less expensive for DMEK than DSEK. And this is if you do your own donor preps or for your eye bank. Now, the advantages and disadvantages of DSEK are basically the same thing. It has stroma. The stroma makes it easier to handle, makes it stick better, but it also leads to increased risk of rejection because of increased antigenic load. And the microkeratome never does a totally parallel cut to the endothelial surface, so it always induces some distortion, and that's why it doesn't have as good a visual acuity. Now, by day 5 after our DMEKs, we have some patients that are seeing 20/20 to 20/40. In fact, most are seeing 20/50. And we have a good number of patients decide to have their second eye done that next week or the week after. And we've shown that that does not increase the risk of immunologic graft rejection. Now, an interesting study that came out last year in JCRS was one from Sweden, where they looked at 33,000 cataract surgeries, and they found that guttae were associated with poor visual results and poor self-assessed visual function. Now, they had 3 conclusions, the first 2 of which we agree with, and the last one we don't. The first was that patients with guttae substantially benefited from cataract surgery. So yeah, that makes sense. And that they had inferior results versus those who had no guttae, and we agree with that. But they went on to say that you should wait 3 weeks after phaco to decide if they need a transplant and wait and see if the edema clears. And we think that's really outdated. So the question is, do guttae matter or does edema matter? Well, actually they both matter. And a lot of the traditional teaching is that guttae don't matter at all. Now our experience, especially since we've been doing DMEK, is that guttae definitely decrease the quality of vision even if there's no edema, and they decrease color perception and detail perception. Now, long-standing edema can be bad because it can lead to loss of stromal tissue and long-term degenerative changes on the surface of the cornea. Now, this is an eye that we've stripped Decimays on the right side. We've just done cataract surgery, and you can see that the red reflex is much clearer on the right side where Decimays and the guttae have been removed. And guttae are basically Latin for drops or raindrops. So think of this as a window with raindrops on it, and one side's had the wiper go by and one hasn't. And that's why the vision's clear. Now in this picture, Decimays is being stripped and it's doubled over. So you have double the Decimays and you really have increased difficulty seeing through that, even with the red reflex. And these are intraoperative OCT images showing that there is some opacity that's picked up with the OCT from Decimays membrane in these cases with Fuchs dystrophy. In fact, I think that really Decimays and Fuchs dystrophy is many times not even clear. It's just that it's very thin. So now this is a video from my partner, Matt Fang, where he's stripping Decimays. And when we have a pseudophakic eye, we usually do this with air in the anterior chamber. And, you know, when people have multifocal lenses, at least we're very ready to do YAG lasers, which is minimal decreases in the capsule clarity, because it makes a bigger difference with a multifocal lens. The vision drops faster as compared to a monofocal. And it's the same thing with multifocal lenses where patients have Fuchs. Those guttae are going to make differences in the quality of the vision. And as we remove the guttae and decimase here, you can actually see that this is an eye with a multifocal lens that really wasn't able to be seen until those guttae were removed. So knowing all this, when's the best time to do cataracts if a patient has both Fuchs that's significant and they have a cataract? Now, in the past, people would routinely, as in Sweden, do the cataract first and then see how much edema they had and go and do the transplant second. And the problem with that is people don't realize they actually have some visual loss from the guttae until you finally remove them. Now, in our practice, most people choose to have their cataract done at the same time. And that's more convenient for the patient and certainly more cost-effective for the healthcare system. The third option is you can do DMEK first if they have a deep anterior chamber, and then a month or two later take out the cataract. And that allows you to have more accurate biometry because the corneal thickness is normal and you don't have any distortion to the epithelium. In fact, if we have patients that want an extended depth of focus or a multifocal lens, or even a very accurate toric lens, we will do the DMEK first, and then 2 or 3 months, a month later, whenever it stabilizes, do the cataract surgery. Now, this is some information one of our other fellows did. Eric Schoenberg's now down in Atlanta. And this shows the scatter plot of how accurate we were with combined cases when we did these in our DMEK cases. And you can see that we aimed for about a half a diopter myopia because, you know, you figure the average change for hyperopia when you do DMEK is about half a diopter. And you can see that basically the scatter plot shows it's all over the place. It's anywhere from a +3 to a -3.5 result. And so this shows the inaccuracy of biometry when there's Fuchs dystrophy. And actually the Swedish studies showed that biometry was not as accurate in people that had guttae as well. Now let's superimpose upon those results. The dark diamonds here are eyes that we did cataract surgery after we did the DMEK. And you can see that there's still a little bit of scatter, but it's much tighter than it was before. And we're in the realm where we're fairly acceptable for multifocal lenses or trying to get a highly accurate toric lens. So DMEK's becoming a mature surgical procedure. And just like phaco, there's probably as many ways to do this as there are surgeons. And I can't go through all those ways tonight. So basically what I'm going to do is talk to you about how I do the surgery. Now, my surgical technique for Fuchs is primarily to do DMEK. And we prep our own tissue. We really don't have our eye bank do it. We don't put any orientation marks on our tissue. We use intraoperative OCT and occasionally a handheld slit beam to determine the orientation. I personally use a trifolded technique. Matt still does endothelium out. And we put this into an IOL injector. We do intraoperative PIs, typically with scissors, and we use air. We do use long-acting gas when we're doing DMEK under a failed PK because there's more difficulty getting those to adhere. Now, this is a video showing a trifold technique where we've stripped decimase, all except for a little area in the center where that purple dot was. We're folding the tissue over so that decimase is on the outside, endothelium's on the inside. I'm going to pull it up now to detach that area in the center. There we go. And I'm going to put a little extra Trypan blue on it. And then we're going to pull it into the cartridge. So the tissue has more touches here than if it's endothelium out. But I think it's made up for the fact that we don't have shear stresses. Now, an important point here is we're using the tissue storage solution from a new bottle, not the one that the donor came in, to decrease the possibility of fungal contamination. Because a lot of times the tissue comes in storage solution, it has a fair amount of debris floating in it. Now, this is an eye that has previously had cataract surgery. In fact, they've had a pars plana vitrectomy, so it's nice and deep, and we're doing a scleral tunnel. We have an AC maintainer, which I just allowed to come out because our anterior chamber is not going to shallow. We don't have to worry about keeping it firm. So we've injected this with the Trifold. And on the right, there's an inset for the intraoperative OCT that you can watch. And you'll see on the far right side how the tissue curls upward. So that part of it is unfolded. We're going to put an air bubble under it. And we do all of our cases under topical anesthesia. We have scleral fixation sutures so we can move the eye when we want to, like here. We're going to use some golf swings to move it into position. Art Giebel in Washington State came up with the golf swings. And once we get it in a position, then we'll fill the anterior chamber with air and we'll be done. Now, Trypan blue is really important when you do surgery. You can't see the donor in the eye very well without it. And if you're doing endothelium out, make sure the Trypan blue goes up the tube when you put it there so that it stains the decimase. Don't leave it in too long because it can be toxic. There's 3 ways that Trypan blue stains this. We also use Trypan blue after we score and strip. On the left side of the picture, you see a very dark area. That's where decimase is detached so that the Trypan blue got in and stained decimase. In the center, you see a light blue. That's where we've already stripped decimase. And then superiorly and to the right, you will see, actually it's nasal and to the right, you'll see some clear areas within the trephination mark, and those are areas where decimase is not detached and hasn't been removed. Now, this is the Etalon handheld slit beam. It's a very inexpensive device. I don't have any financial benefit from this, but it helps identify the orientation of the donor. What we see here is a schematic on the right and pictures on the left. And you want to have the tissue, when it's in the eye, endothelium out, and that would be the upper picture. And so when the slit beam goes on that, you get the reflections, 2 little curvatures as you see in A, where the arrows are, and that's curled the right way. B shows the wrong way, where it's actually flipped upside down, and so if you see that, then you need to flip it back. Now, what we like to use is the Intra-Operative OCT. This is the one from Hog Stripe. And on the left is a picture that we took with an iPhone through one of the oculars. And this is an injection image that you can turn on and off with a foot switch. When it's on, you see the purple line. That's actually where the cut's being taken for the OCT. Below that, you see the injection image, and that shows what the OCT is taking a picture of. You see the iris, the cornea, and then you see how the donor is curled. It's a young donor. I think this is one in the low 40s, high 30s. So it's tightly curled, and it's curled endothelium out, and so you can see it's curled the correct way. And then on the right, you see the picture in the monitor. That's what the assistant can see. They don't have it in their scope. And then in the lower picture on the right is the picture on the wall. The picture on the wall is what you'll see in all the videos I show or that other people show. And it's not the injection image that the surgeon sees. Only the surgeon sees where the cut is and sees the injection image. Now, this is another trifold technique. This is a phakic patient. And when Massimo Busson introduced this, he said, well, you can use this for young donors. What we find is that when you get into the low 40s and into the 30s, the donors typically recurl on their own, even with the smaller bore cartridges, and they go endothelium out. So we're going to get this into the eye. Once again, I have an AC maintainer that we're going to leave on until the donor gets to the far side of the angle. When it gets to the nasal side of the angle, then we're going to turn off the infusion. because at that point we would like to have the AC shallow a little bit to hold the donor in place while we pull the cartridge out of the eye. So we're going to inject it here. And once again, you can also look at the inset of the OCT image on the right, and you'll see how the section on the right is unfolding the correct way. So now we've got it into the far angle, so I've turned off the infusion from the AC maintainer, taken the AC maintainer out, and we're going to check it. And if you look right in the far angle, kind of where the arrow is, you're going to see the edge of the graft curled upwards. So it's curled the correct way, endothelium out. So that means we can go ahead and unfold it and proceed with the case. So the left side is still in the trifold position. The iris kind of catches it, so we're going to help it unfold there. And a tip here, if you're doing phakic eyes, you really don't want your needle to go into the pupillary area and possibly damage the lens. So instead of going in the very center to inject air, we'll be injecting the air off to the side a little bit. And so once again, we'll use the golf swings to move it into position. Now, let's talk about the long-term effects. When we started doing endothelial keratoplasty, we were really concerned because we had a rapid loss of cells the first few months after surgery from just the surgical trauma or the preparation of the tissue. So this was a study we did comparing DSEK cell counts to the corneal donor study reports as cell counts. And what we can see here is that at 6 months compared to PK, the DSEK eyes started out with a lower cell count, but their cell loss was linear instead of almost an exponential type loss or an early increased loss in the PKs until the PKs at around 5 years began to plateau off. But still at 10 years, the DSEK eyes had a higher cell count. Now this looks at some early results we have. We went back and looked at our first 400 DSEK cases and our first 400 DMEK cases that we did. And these are in our early times when we were just learning how to do it. And you can see our indications here. Failed keratoplasty is not just PKs, but were endothelial keratoplasties that failed, that were redone. And you can see the majority of cases were for Fuchs. And this shows the plots for the cell loss over time. And we were actually going to really beef these numbers up this year, but COVID kind of got in the way. But we still have enough to show you some of these preliminary results tonight. And you can see that we had a linear loss in DSEK up through 10 years. And then just like the PKs, it begins to plateau between 10 and 15 years and levels out. And DMEK, once again, we have linear through 10 years. This shows the median cell loss over time, and we compared it to the corneal donor study. And you can see that the results of DSEK and DMEK were pretty similar for years 1 to 5. And we'll see how it is as we get more numbers, whether DMEK ends up being better than DSEK, but we still need to get more numbers there because we just started doing DMEK in 2008. You can also see that by 15 years, it's leveled out for the DSEK eyes. Very little change between 10 and 15 years. So that's encouraging. Now, what about pharmaceutical options? I don't know if you guys have heard, but there's some people saying, well, gee, maybe we don't even have to graft these people at all. And so there's been some talk of using Utarsadil to treat Fuchs patients because it can decrease central corneal thickness, improve vision. Question is, what does it do with visual quality? And what about the honeycomb epithelium that sometimes occurs? So we did a study Notarsidil is a ROK kinase inhibitor, a ROC inhibitor. It's approved in the United States by the FDA to treat glaucoma. It's called Ropressa, is a brand name. And as we know, ROC inhibitors act on the cytoskeleton of the endothelium. They reduce tension on cell-cell junctions. They may reduce leakage of aqueous and allow the pumps to better maintain hydration. Now, what we looked at were measurements at screening 1 month and 3 months: corneal thickness, scotopic best corrected visual acuity, intraocular pressure, the surface asymmetry index on topography, and visual disabilities. So here's the data on corneal thickness, and it did decrease corneal thickness. You can see that we had a significant decrease that leveled out between 1 and 3 months in the notarsidil group, and placebo didn't change, which you would hope your placebo group is stable or getting worse. This shows the change in best corrected visual acuity. It did improve on notarsidil and actually continued to improve through the 3 months. And once again, the placebo group didn't really change at all. Intraocular pressure decreased in the notarsidil group and stayed the same in placebo. Now, when we looked at the surface asymmetry index, we saw that it didn't really change significantly in the notarsidil group. And more importantly, when we looked at the visual disability scores that have been developed for Fuchs dystrophy, that did not improve either. So even though the visual acuity got better, the patients didn't feel like their vision had improved that much on the notarsidil as compared to without it. So that's something to think about. What about DSO and DWEK? Who are candidates? What's the surgical technique? And what's the surgical pitfalls? Because 20% of our listeners tonight would like to have this done. So let's talk about that. So who's the ideal candidate? Well, usually it's said that those that have primarily central guttae and are possibly younger are going to be the best candidates. Now, Mark Gorovoy, who's probably done the most of these, told me he doesn't think this really matters. You can't really tell who it's going to work on and who it's not. One of the things we've found when we're doing this for patients, they have to be people that have an ability to wait a few weeks for visual recovery, because it can be anywhere from 2 weeks to 2 months before their cornea is going to clear. Now, what are the advantages? Well, no long-term use of steroids and no rebubbles. And that can actually, both of those can be pretty advantageous. So in the United States, we currently, that we know of, have 2 studies. CAWA with Reposidil. You may have access to that in Canada, I'm not sure. That's a pivotal trial for approval to treat Fuchs dystrophy, and that's being done in the United States with DSO. It's a placebo-controlled study, and it cannot be done with combined phaco or IOLs. Notarsidil, we have a physician-sponsored study in our practice where it's also placebo-controlled, and we wrote ours so that we can do it with phaco at the same time. Now, I'm going to just show a few little tips. Since it's only a 4 to 4.5 millimeter zone that you're stripping, you want to make sure you get it centered well. And you can see here, I actually did 2 marks before I had one that I liked. I'm going to do a stab incision and a keratome incision, 2.8. We use some 1% lidocaine in the anterior chamber first, and then I filled the AC with viscoelastic. So these are Gorovoy forceps that are very blunt, and what we want to do is carefully break decimase without causing any disruption to the stroma. And if you do DMEK or DSEK, the posterior stroma is very soft and it's easy to tear it. So once we get a loose piece, then somewhat like a capsulotomy, we're going to start to try to do a continuous tear around this area that we've outlined, trying to keep it inside of that mark so that it's not too large. So I usually aim for about 4.5 millimeters, 4 to 4.5. And one of the nice things about this, it gives you something to do with you know, 1 or 2 of your old RK markers if you used to do radiokeratotomy. But you can see here that we're gently tearing this, and we're going to remove descimase and guttae in this central area. And there'll actually be multiple tears before we get this done. But the key is not to disrupt the stroma. So it's a limited removal of the guttae, 4 to 4.5 millimeters. And some of us had done this before with 6 millimeter removals with not so good results. And it may have been partly because it was that large of a removal, and partly because we probably weren't so aware of how important it was not to leave rough stroma or stromal tags, because those can lead to non-healing defects on the endothelium, and they can also have chronic inflammation and fluctuating vision indefinitely. So this is an OCT photograph showing one of those areas where we have some actually scarring that's developed from where there was rough stroma. This is from a publication that we had in cornea back in 2014. These were all 6 millimeter areas that we stripped. And what you see is a progression, 1 month, 5 months, 17 months, and 4 years, that shows persistent edema where we had some loose stroma. Just a small little area, and that persisted and didn't go away. And at 4 years, you can see the irregular topography that really distorts the vision in this patient's eye. Okay, so where does the future lead? Well, I think to know where the future might go, we need to look at the past. We need to know what would be ideal, and then we'll talk a little bit about current research. So Moore's law with computing was that every 2 years the computing power would double in speed, and that the cost per speed would be cut in half. So your cost would stay about the same for computers. And he's been pretty right. Now, can we say that about corneas? No, not really, but it's not too bad with corneas. Up until the year 2000, the options were PK or a hair dryer. Now, some of the younger doctors may go, what are you talking about with hair dryers? Well, back then, PKs were so unpredictable for the refractive effect and their limitations on activities that a lot of doctors told their patients with Fuchs just use hair dryers to dry out their cornea and decrease the edema. In 2001, Garrett Mellis was teaching PLK, posterior lamellar keratoplasty. Mark Terry then renamed it in the US DWEK, and that was being done. In 2003, Garrett Mellis talked about DSEK at the American Academy, and I started doing those in the US in December of 2003. In early 2008, we began doing DMEK, and then by 2016, we were getting reports of good DSO results with the smaller zones, and that was being done. And we also were beginning to hear about the injection of cultured endothelial cells as well. So what would be ideal? I think it would be ideal if we could regenerate a patient's own cells, or in the case of Fuchs dystrophy, regenerate cells that were genetically improved without the tendency to make guttae. With Fuchs, I think we need to remove the guttae to get good vision. We have to have a way of regenerating these cells without compromising the intraocular pressure, the trabecular meshwork, or if they have a filter, making the filters fail. Likewise, we need to mitigate the negative effects of tubes and trabs on our corneal endotheliums. So where does the future lead? I think we're going to have improved pharmacologic agents to allow endothelial regeneration. And this will be especially helpful in cases of trauma, glaucoma, and uveitis. We'll also have potentially pharmacologic agents to maximize the viability of the endothelial grafts when we do those, and to minimize immunologic reactions. So what does that mean? Well, I think there's going to be fewer transplants done in 20 years than what we're doing now. What about cultured endothelial cells? There's multiple groups doing this. Probably the most experience is in Japan with Dr. Kinoshita, and he's now working with CorneaGen. They have 6 years of follow-up, which is pretty impressive. Emicell is culturing cells, and they're injecting magnetic beads that go into the endothelial cells so that they can localize where those cells go when they're put in the eye by putting a magnet next to the cornea. Now, what's interesting is that endothelial cells don't like to attach to bare stroma. And the cultured cells do best if they can be attached to Descemet's membrane that's already present. The difficulty we have is that in Fuchs, we need to remove Descemet's. And there's projects working on carriers. Jod Mehta, who I think has also talked for you all, is working on transplanting just Descemet's membrane from donors. And the people at Johns Hopkins are working on a manufactured carrier. Now I'm going to finish up by talking about the surgical OCT, which I think is really going to be more and more important as we're able to afford these devices. And when you're looking at a OCT, you need to look at the quality of the image in the oculars, as well as the quality of the video image. The video image is good for giving talks and doing papers, but the quality of the image in the oculars is what's going to help you in surgery. You want to see how easy it is to use and whether it's part of the microscope or separate. Why is that important? Well, if you have to have it worked on, you don't want to have your whole microscope going down. And I wish I could say there was some competitive cost differences, but there don't appear to be at this time. So once again, this is the injection image that we can turn on and off with the foot switch and see it in our operating microscope. And to my knowledge, this is the only unit that you can actually use to operate real time through the oculars with without looking at the monitor. This is a Hogstrite unit with the monitor attached to the side that the assistant can look at. And this is once again the 3 ways that you can see it. Now, intraoperative OCT gives you real-time OCT images of the cornea, anterior chamber, and posterior chamber. You could give a whole talk on what it can do for the retina as well. And the injection image goes into the oculars, both oculars. And we use it for DMEK, DSEK, DWEK, and complex cataracts. So let's say you have a cloudy cornea, like the one on the left. I'm not sure an S stamp's going to help you out much here when you get that into the eye. You're going to have to somehow dehydrate the cornea. But we can get a great view of that with the intraoperative OCT. And this has actually been enhanced a little bit so you can see it better on the picture. But this is a trifold once again, as you've seen in some of the videos, where the right side is already unfolded. You can see it curved the correct way, and the left side has not unfolded from the trifold yet. Now, why is this important? Because this is what's going on the eye on the left. And so when I see this in my injection image, I can go in with my needle and put my needle in the right spot, put the air bubble under there, and I can even use the OCT when I start to lose dye on my donor to tell where it's oriented inside of the eye. And that can be a big help in these difficult cases. So I said we can use it for other things than DMEK. For DSEK, we can use it to look for the space between the donor and the recipient. We don't have to do venting incisions anymore. We can massage it until we have good apposition. But I think the big game changers can be using this with DWEK for what we can do with the bed. Now this is another DMEK case. This is a blue bloater, no neck. We had to use hooks to dilate his pupil. He had weak zonules. I put a CTR in. So I really don't want to mess around in this case. So once again, we're going to be able with a trifold to easily get this into the eye, maintain the chamber without a lot of ups and downs with the AC maintainer. So we slowly inject it. Now we're going to turn off the infusion, pull the AC maintainer out. There we go, a little slow on that. And by the time I get the suture in, there's a little bit of blood. But once again, just like in the other cases, we can check and see how it's unfolding. Get it to unfold. And if you look at the inset, once we get one side to unfold all the way and not be stuck by the iris, you'll see that it has the right curvature. So we're just moving it into position where we can see it. Now these are some pictures of that are important. The one on the top shows an irregular bed that's hard to really tell with the coaxial microscope, but if you put a graft on top of that, that eye's not going to see. You have to go back and you're going to have to thin that area that's shown in B to get it nice and thin. C is actually a big bubble, and you can see that with the OCT it looks a little bit thicker than you might anticipate, but that's the way that the OCT magnifies the image. And the bottom is a really interesting case. This is a case of a previous doc where I did a cataract, and when I put fluid in the wound to hydrate it, I separated the donor and the recipient. That was fun. So here's the one again with the irregular bed in the upper left. And in the lower right, this is an eye that I didn't get a big bubble, have a lot of errors you can see, but I dissected down to where it's nice and thin, as you can see in the inset. Thin enough that I know that that's going to be pretty close to what we get with a big bubble. I can do a peel technique and get a great result, and I know that I'm at the right depth. Now, this is the case that I just showed that one picture on. This is a keratoconus eye, has a fairly large diameter graft. We did a DWEK. I just finished the cataract. I put some sutures in the keratome incision because it's thin and it's kind of leaky. And so because it's thin and leaky, I'm going to use a little extra pressure to hydrate my stab incision. And as I go in to do the stab incision, watch the center of the cornea. You're going to see a little fluid wave here. See it? Now the question is, with the coaxial microscope, what are you going to do with that? I mean, is it anything you really need to worry about? You just finish the case and leave. How significant is it? Well, when we look at that with the OCT, you're going to see that it's actually, it's magnified some, but you're going to see that in some areas, like right there, it's pretty deep. And that once the pressure goes down and equilibrates between the anterior and posterior chamber, IOL is probably going to be up against that endothelium. And of course, the drawback here is you don't see where the cut's being made. Now, you have a choice. You can either open the incision, the old transplant incision like I'm doing here, or you can make a little venting incision in the graft itself, which I've done in some cases. But here I looked at it, I thought that was probably the best place to do it. And so I'm venting the fluid from that interface. And what I'm going to do is intermittently refill the anterior chamber and keep it firm so that when I vent it, it pushes the fluid out. We're going to fill the AC through a different incision. Here I'm doing some of it through the main keratome incision. And as I fill the AC and make it firm, you can see the space between the donor and recipient go away. And I'm going to vent it a little bit more, and you'll see that the space goes away completely now. We have it reattached. And I think only with intraoperative OCT can you really do this. And the next day, this case looked perfect. You couldn't tell there were any problems. So that brings me to the end of my talk. And I don't know where it is in Ottawa, but here it's gotten dark. And what would you recommend now for treatment of a patient with decreased vision from Fuchs dystrophy? So we'll see if I changed anybody's ideas here. Whoa. I guess we got some objectives done, 100% DMEK. That's pretty amazing. Okay, we'll go to the next question. Oh, I guess I have to move that, don't I? Sorry, I'm asleep at the switch. If you needed visual correction for Fuchs, which would you want? Same choices. Oh, a little bit pretty similar. Interesting. Well, I think that's always interesting to see what the doctors would want for themselves. And then, of course, the final question, in 10 years, after you've heard my talk, do you think we'll be doing more or less corneal transplants? I think it says question 3, but it's really the same as question 2. That's the wrong question. Unless it's yes and no, I guess. Looks like it's the answer from that. There we go. Interesting. Yeah, I mean, that's what I think. So those of us that know how to do transplants well in suture, I think will still be busy. But overall, I think there'll be fewer grafts done. So I hope that you all found this talk interesting. And it was what you wanted, Kashif, for this meeting.
Great, thank you so much. That was really nice overview of DMEK, DSEC, and what we have in future for our patients. We would welcome any questions from the attendees. You can either text them in or whatever, but I have a few questions to start off with. So Dr. Price, your Ropressa, what role does that play in your practice right now for patients that come to you?
We use it for glaucoma. And that's probably the main thing, and we're doing the DSO study with it. And I really can't tell you the results of the DSO study. I'm supposed to be blinded to it. Do you guys have Reposidil?
So we have, no we don't. So we basically have to ask our patients to order it online. It's not in the pharmacy. So we've done a handful of DSO patients, but without the ROCK inhibitor, which many people have found to be an important part of recovery. And so some of the questions we have, not having had these ROCK inhibitors and trying to get our patients to get them, is, at what point do you start it? Do you use it as salvage therapy? Do you start it off right away? How often, how frequently do you use it per day? So these are something that we're going through, and we're trying to get a multi-center kind of trial going on here. We just submitted a grant actually for our center to do a DSO study. But that's where we're at right now.
Yeah, I think that for sure you want to have it as a rescue. I don't know if there's any head-to-head comparisons between the two. The Notarsidil is quite a bit stronger and has more penetration in the cornea. So you don't need to use it 4 times a day. When we use it, we're just using it once a day.
Okay.
And that seems to be plenty for that, as compared to Reposidil, where I think they typically recommend that 4 times a day. So one of the difficulties with using the Notarsidil in a blinded study is that you're really not blinded because you can tell which eyes have it.
Okay.
You have that available there for glaucoma?
No.
Oh, okay. Well, if you read the package insert for it, it's very common to get red eyes, and you even get deposits in the cornea as well in probably a third of the patients.
Okay. We have a question from Argentina. What's your experience when doing EK for failed DSO?
I haven't had to do that yet. Well, I guess I have, because those first 3 I showed, I regrafted 2 of those, and DMEK works fine, no problem. You do want to strip the area of remaining decimes if you can.
Okay. And so when you are looking at these patients who are potential DSO candidates, what's your assessment of the peripheral cornea, guttae, and endothelium consist of?
Well, on the slit lamp exam, I'm personally trying to pick people that primarily have central guttae. One of the issues I have about, half the people I do are from out of state, and they really don't want something that's going to take a few weeks to get their vision back. They would like to be fixed right away and be on their way. Now, I had a lady in this week that has pretty much diffuse guttae. I'm either doing her tomorrow or next week. I have to at which time she got put on. We're going to do DSO because she'd actually had topical steroids in the past for Graves' disease, and her pressures went up in the high 30s. So we would like to avoid topical steroids in her post-op. So she'll be the first one I've done that's had diffuse guttae out, you know, to the peripheral cornea. But in my experience, I try to keep it for the people that just have it in the center. As I mentioned, Mark Gorovoy doesn't worry about that. He says it's working fine.
I was curious about the your OCT. So it seems like you're able to do quite a bit without marking. And I think in Canada, Michelle Mabon may speak to this more, at the University of Montreal, Maison Rosemont Hospital, I believe they're the only place that has an OCT that can do it. So I'm wondering, Michelle, are you also finding your experience with the OCT as what Dr. Price described?
Well, can you hear me?
Yes.
Yes.
Hi to everyone. Very interesting talk, by the way. We have the Zeiss OCT, and the challenge, it's a very useful tool, but it is very challenging to do the surgery while using the eyepiece, so to speak, as in, you know, you have a good idea, but you're not seeing what you're seeing with the, did you say yours was the Bausch and Lomb?
No, ours is Hog Strike.
Hog Strike. Because the image is very small and it's colored in a gray scale, just as yours is, but it's not magnified, so it's teeny tiny. You do get used to getting a good idea, but we're often turning our head to look at the screen. But it's a very useful tool. You know, when we didn't have it, we didn't know what we didn't know. And now we see, it gives you more information. I do mark my tissues, so I have that advantage, but there's the disadvantage of having cell loss associated with the S stamp that we use. But overall, it's a very beautiful, beautiful tool.
Okay. Thanks, Michelle. Good to hear from you.
Yeah, one of the problems is that like Zeiss and Hogstrite all have intraoperative OCTs, but they only work on their respective microscopes. So not only is the OCT expensive, but you have to have that particular microscope. I have used the Zeiss, and I didn't mark the tissue, and I was pretty disappointed when I was actually doing the surgery to find I couldn't tell what was going on through the oculars either. So there's a huge difference between the different devices for that. And if we ever have a meeting again where you get to go and try things out at the booth, I would look at the Hog-Strite device, or maybe get them to bring it in and try it out.
Right. Okay. We have a question from Darrell Lewis. Darrell Lewis is a cornea specialist that just has joined our team at PCC from Halifax. He says, "Thank you so much for the fantastic talk. I'm hoping that you might have some thoughts on the use of ROCK inhibitors for the prevention of retrocorneal fibrous membranes, as we sometimes see in our glaucoma tube shunt patients."
No, Daryl, I don't have any ideas on that. I'm not sure. We don't see those retrocorneal membranes. Maybe you need to use more steroids. It doesn't cause as much inflammation as the prostamides does in the eye, but they definitely cause a red eye. So I don't know if they're going to be helpful in decreasing an inflammatory membrane that you might see.
And for a DSO, are there certain signs that you're seeing that are kind of new to the slit lamp exam that have helped you in terms of gauging how recovery is going and how clearance is going?
No, it's just that, you know, you get a lot of edema at first, and the endothelial cells slowly migrate over that denuded area. And then once they do recover, it's still a little hazy for a while. And recently I was on a meeting where Dr. Maloney from Australia, who's done a lot with Repositol, was talking. And he actually said that he's had a few cases of rebound where once it healed, and they stopped the Reposidil, that the edema rebounded, and they had to start the patient back on it. So that's one thing to watch when you're doing your cases. You may have to keep it going for a while after it looks like it's healed.
Yeah, I think for our study that we submitted a grant for, we had Reposidil going in 4 times a day, and then once clearance was achieved, going down to twice a day for a certain amount of time thereafter. So we'll see how that goes.
Yeah, that sounds like a good idea.
Yeah. Okay, cool. And another question I had with respect to DSO is, what do you tell the patients? Because there's reports of, there's, variable shift in refraction that can take place, some higher order aberrations or irregular cylinder in the center. So what are you telling patients of what they may expect for clearance and for visual acuity or visual quality afterwards?
Well, Kashif, let me ask you a little bit here. Have you heard other reports of irregular astigmatism with DSO, or just what I talked about tonight?
I've heard there's some in the Vancouver group of Ioviano, his publication, they talked about some irregular cell.
Yeah. Yeah, I had missed that, and I haven't heard anybody else talk about it but us. But I don't really mention that right now because I don't know how much of that in our early cases were because we were stripping a 6mm area, and we definitely had some rough areas of stroma, which we've actually had with some of our newer ones. Mark Gorvoy says it takes about 50 cases to get good at DSO. I was kind of disappointed to hear that, but you need to be really, really careful. That's why I showed that to you. What I tell my patients is that it can take, a month or two for their edema to go away. And so most of my patients are choosing DMEK because they don't want to do the prolonged period. Now, Mark Gorvoy is doing a lot of it because he's telling them they don't have to worry about a risk of getting a fungal infection.
Interesting.
I guess that's one way if you want to push people to DSO. Now, in our data, it's like, the fungal infections are like 1 in 1,500. So it's not very common. It's there, but there's a lot of other risks going on.
Sure.
So, that's a good question. I think a lot of it depends on what the surgeon tells the patient. And, we know that DMEK gives us really, really good results. As I showed tonight, and as a lot of people thought when they said what they'd recommend or want to have. We just don't know how it's going to stack up with DSO. Now, one thing you all in Canada can appreciate, I once did a head-to-head about DSO versus DMEK, and I showed a picture of somebody that on their windshield just scraped off a little area to look through with ice on it. And I was told that wasn't fair. But that's been my concern. Now, Mark Gorvoy says none of his patients complain about that, because we know that with IOLs and refractive surgery, that if you only have a 4mm optical zone, the patients are not happy. But these Fuchs patients may be more tolerant of the guttae and the smaller opening.
Okay.
So, we're just going to have to wait and see as we get more numbers on that.
Okay. 2 final questions. How long do you wait until you know that the DSO has failed? Perhaps you can.
Yeah, that's
what you think about
question.
That.
I would probably wait at least 2 months, and having used a rescue medication for 3 to 4 weeks.
Okay. And the second question, and perhaps the final question, as it's just a little bit past 6, is we know the endothelium of these patients are not normal, even in beyond the 4mm zone. So what are we looking at, say, 5 years after DSO, when the rest of this, say, the peripheral cells have changed? What are your thoughts about what we should anticipate in terms of managing these patients several years down the road?
Well, Kashif, that's a great question. It took most of these people 40 or 50 years to get guttae that were significant. So we'll just have to wait and see how quick the guttae come back. I just don't think we know. But we also know that all the grafts don't last forever. So,
Right.
you know, who knows? I think DMEK's been really pretty remarkable in that we've been able to cut the steroids so much. And we keep them on fluoromethalone like 1 drop a day if we can. And, you know, that's, we hardly see any rejections at all. And most of the patients are doing great. So we're just going to have to wait and see which ways are better. And we're doing people younger and younger, so that gives more potential for problems with both DSO and DMEK.
Awesome. Well, thank you so much for your time, Dr. Price. Thanks for continuing to educate us all, and appreciate very much the presentation and your comments on the questions that have been raised. As I mentioned, we'll have this on our YouTube channel in a little bit, and we'll talk later on, Dr. Price, about what we had discussed before. And have a great night. Thank you so much for your time, and say hi to Marianne.
I will. Thanks. And it was fun being with you guys tonight.
All right. Take care. Good night.
Bye.